So it's a pleasure to be here amongst you today in this prestigious gathering for tackling the microbiome. I thank Sandoz for the invitation. Is the sound clear? حضراتكم سامعيني؟ لا؟ تمام. أفك المايك. حضراتكم سامعيني كده؟ تمام. Okay. So I'll take the thread from here. I'll speak most of the time in English because this is a costed webinar. So a mix with the English and the Arabic. I'll talk about probiotics in early stages of development. Dr. Sanat started the journey with the microbiome and the maternal probiotics, taking it to Dr. Christus. We need to know what is the really difference between the microbiota and the microbiome. They are terminologies. The last 10 years, the last 20 years were all research about how this microbiota and how this microbiome changes our lives. It changes how we live, how health is perceived. So we need to answer what are the factors affecting these in early life and the role of microbiome in early life. I start by a saying by Hippocrates 4000 BC about death sits in the bowels. A bad digestion is the root of all evil. He was right. All the research, all the modern research now is taking us to the programming of the microbiota, programming of the microbiome. What is the microbiome and what is the difference between the microbiome and the microbiota? 10 to 1, sorry. 10 to 1 is the number of the microbial cells in relation to the human cells. So for every human cell, we have 10 more microbial cells in our body. So 10 times more than our human cells. We better work on our human cells or our microbial cells. Actually, it's an environment living on us. It's a complete ecosystem with direct communication with all the systems, the endocrine, the immune system, and the brain. 1,000 different species, 170 bacterial species out of the total 1,000 are predominant in the gut. 150 times as many genes as our own genomes. So actually, we are bacteria with human cells. We are a bacterial environment with human cells. And most of this microbiota resides in the GI. And the gut is actually our largest immune system. It represents 70 to 80%. And it harbors more than 80% of this microbiota that we're talking about. And there's a crosstalk between the gut microbiota and the immune system. A healthy gut microbiota is a healthy life, a healthy adult. The microbiome is the whole environment. The microbiome is the microbiota, plus the genes of the microbiota, plus the cell structure of the microbiota, and the metabolites that these microbial cells do when they ferment or when they die. So it's the whole environment. The whole environment is the microbiome. And this microbiome sets early on from maternity till the birth, whether the child is delivered by vaginal delivery with beneficial bacteria and diverse flora, whether the child was delivered by C-section with decrease in the diversity and increase in the pathogenic bacteria. And as we go on, the journey continues with multiple diversity and multiple microbiota through our life. It's not only diversity and types of bacteria, it's even the place. Exposure to microbes begins in utero, and the gut flora is established within 1 to 2 years of birth. We have the oral microbiome. The bacteria that resides in my oral cavity can predispose me to diseases like caries and gingivitis. The placental microbiota mentioned by Professor Sanat and the vaginal microbiota, predisposing them to STDs, vaginosis, and yeast infections. The skin microbiota with the skin troubles, the allergies, the acne, the psoriasis. So every place has its own bacteria, and the disruption in the diversity or in the type of this bacteria will cause disease eventually. Infant exposures help define the intestinal microbiota, and this is a very nice diagram telling us that the green are the favorable conditions, the vaginal delivery, the exposure to the environment, the home delivery, the daycare, the children going to the daycare, acquiring a lot of diversity, the household pets, if you have pets, all this increase in the relative abundance, in the diversity, and overall bacterial community that is favorable. If you're having a C-section child with a repeated courses of antibiotics, which we face in our children, premature hospital delivery, all these will decrease the relative abundance and reduce the diversity of the overall bacteria. We aim for the good bacteria, the bifido and lactobacilli, they are the stars here. And we tend to decrease the pathological bacteria like the Campi, the Enterococcus, and the Clostridium difficile. They act the microbiome for the metabolism, promotion of fat storage, promotion of angiogenesis. More important is the immune system, the pathogen resistance, and the immune system stimulation. So they work on putting milestones for our health later on. We focus on the protective function against pathogenic bacteria, whether it's pathogen displacement, nutrient competition, they compete with the bacteria, and activation of the local immune response in the GIT, immune development, production of IgA, control of local and general inflammation, induction of tolerance to food, what Professor Christos was just telling us about, digestive and metabolic function, vitamin production, fermentation of prebiotics with the short-chain fatty acids that are beneficial for health, and the brain development modulation of the gut-brain axis. So the gut-brain connection is really important. If you have favorable microbiota, optimum microbiome, you will have a good brain development, decrease in the anxiety and the stress, depression, and the pain. All this is affected by the microbiota. On the other hand, if you're having dysbiosis, pathological bacteria, you will have increase in the stress and alteration, social alteration, sensitivity, stress, and depression. The gut microbiome even regulates our host immune response to viral vaccines. If you're having good microbiota, you will have good response to the vaccine the child is taking. So the microbiota affects even how we respond to the vaccine that is given. The first 1,000 days is development of the immunity by the gut microbiota. We aim for programming with the beneficial bacteria and avoiding dysbiosis. And dysbiosis is not only increase in pathogenic bacteria, it is reduction in the diversity, and it is decrease in the beneficial bacteria as well. So dysbiosis can mean not only pathologic bacteria, but the beneficial are low. We need to increase the beneficial for the optimum environment that we need to, for the homeostasis to occur in the microbiota. And dysbiosis is disease. DD, dysbiosis is disease, with prediction more for the immune disease, the autoimmune disease, the atopy, the asthma. Children with disrupted microbiota are more prone to autoimmune disease, allergic disease, intestinal disease, inflammatory disease, and metabolic disorders. So how to work on this microbiome, on these cells, on this environment that resides within us? Manipulation of the human gut microbiome started the prebiotics by Eli Metchenkov in 1916 with a probiotic. And we've been through a long journey about defining what is a probiotic, what is a beneficial probiotic. And they decided that this is introduction of live bacteria. And this is the first condition that should be there in this probiotic. It should be living, it should be live bacteria, and it should be in adequate amounts, in amounts that is enough to have health benefits to the host. And we will know more and more how they are strain specific and how they confer the health benefits to the host. The prebiotics, they are the lunchbox of the probiotics. They are the feeding of the probiotics. Non-digestible carbohydrates, we serve as food for these probiotics, and both of them are the symbiotics for the optimum health. I just added these slides, the latest definitions of the ISAP for the postbiotics, because even the degradation products and the preparation of inanimate microorganisms and the fermentation of these probiotics, the cell wall and the inanimate materials, they also have health benefits to the host. So it's the whole microbiome. It's the whole environment. I need to program the whole environment with the probiotic, giving the prebiotic for the symbiosis, and even the postbiotic will have an optimum microbiota. They have non-immunological and immunological functions. Immunological functions enhancing specific and non-specific immune response, competitive inhibition with the pathogens, stimulate GI immunity, reduce the chance of infection. Non-immunological, they promote recovery from a lot of GI diseases. They produce lactase, which can help in partial lactase deficiency, relieve constipation, and they even treat colitis. So how to name a probiotic bacteria? We always hear the words bifidobacteria, lactobacilli, then a name, then a number, then a lot of debates. What is the difference? So this is the genus, the bifidobacterium. The species is the lactis, for example. This is an example. And the strain is the BB12. Why do we need to name each probiotic bacteria? Because each one, each strain is disease specific. So a lot of genus, a lot of species, a lot of strains. Why the strains? Not just a probiotic, because they are specific. Not all probiotics are created equal, and the supplements, sometimes they make unproven claims. So how to criteria of eligibility of this probiotic. Is this probiotic working? Not every company coming telling us that this is strain that is working, it is eligible to be a probiotic. It has to survive the digestive system, attach to the intestinal epithelium, carry no antibiotic resistance gene, produce antimicrobial compounds, organic acids, and has a beneficial effect to the host. Not only this, they have the probiotics are sensitive to the oxygen, heat, and moisture. They have to be live bacteria or live bacteria. The timing and the optimal dosage, you have to know that there is at least a colony count that is beneficial to the host, and it has to be evidence-based. And of course, the effectivity and the evidence on this strain that is effective in this specific disease. Long-term viability is really important. Probiotics, they should be alive when ingested. Shelf life, they need to be alive when ingested in the GIT, resistant and passing through the GIT. Multiple strains in one product does not necessarily provide a greater number of health benefits. Not the more the merrier. So it's maybe the combination should be effective and evidence-based. Effective as evidence, as proved by evidence. Just the right amount, just the right amount of the colony count, 10 to the power of how many, and 500 million to 50 billion colony forming unit had been associated with various health effects. Probiotics and early life. The controversy in probiotics, a lot of disease has been established and evidence-based with good evidence regarding their beneficial effect on the host. Always there has been a controversy on giving probiotics to premature children because they are a highly vulnerable group, and the susceptibility to the sepsis and to the neck and to the late onset sepsis is really high. In the 2000s to the 2020s, there have been an era of probiotic trials on these prematures and era of microbiome characterizations, characterizing the microbiome of the premature, how this affects the life journey of a premature infant. So the premature has a lot of factors. C-section, he's less breastfed, if he ever is breastfed. NICU, a lot of microbes, a lot of sepsis in the NICU, delayed establishment of the microbiota, inadequate gut-associated lymphoid tissue maturation, gut barrier, it's leaky gut, poor humoral and cellular immune response, a lot of factors. And we find here that this is the vaginal delivery with the healthy term baby, with increasing in the bifido and lactobacilli and decreasing the pathogenic bacteria. The preterm delivery is associated with a lot of maternal, as mentioned in the first, whether she has chorioamnitis, gestational age is premature, C-section, type of milk, if he's ever breastfed, is probably formula, taking antibiotics. The environment of the NICU will increase the risk of dysbiosis, the firmicutes are increased, the proteobacteria are increased, and eventually the neck, the necrotizing enterocolitis, the late onset sepsis risk is highly increased. This is a review of literature in 2020 about probiotics, how they reduce the mortality and morbidity in preterm and low birth weight infants. And it shows a great effect, especially the combination of lacto and bifidobacteria in the improvement in the odds of mortality. This was another trial with a preterm cohort versus supplemented with the bifido and lacto versus another cohort non-supplemented. And we see the big blue circle. The big blue circle represents the bifidobacterium. This is what we aim for with the diversity in the microbiome of the preterm child. And on the other hand, the non-supplemented, the one who did not take the bifido and lacto, shows a lot of Klebsiella, E. coli, and Enterococcus. This is another nice review, 2020, about probiotics for premature infants or free preterms. Time to end all controversies. Over 25 systemic reviews and meta-analysis have reported that they reduce the risk of all-cause mortality, the neck, especially in special stages, and the late onset sepsis and feeling intolerance in preterm infants. Okay, this is another review about the benefits of probiotic in premature in low-income and medium-income countries, systemic review of RCTs, and it shows that the risk of late-onset sepsis decreased from 18% to 14% in preterm supplemented with probiotics. Mortality decreased from 8 to 6%, and the neck decreased from 6.9 to 3.9% in these patients. Another study about the research in the recent 10 years, in the last 10 years, about the study of probiotics in prematurity. And probiotics, a lot of strains were given: Lactobacillus acidophilus, Rhamnosus, Reuteri, Brevi, Bifidum, Bifidobacterium brevi, and Bifidum, and there were beneficial effects. Some studies highlighted the beneficial effects of this supplementation, some did not show any result, and this is why there was a controversy. This is a probiotic for promoting feed intolerance in very low birth weight infants, and the mean time did not differ between the two case controls, and yet there was a trend towards lower necrotizing enterocolitis in the probiotic group. This is another review article, 2022, about that the same results. They decreased the neck, they decreased the late onset sepsis and the hospital stay and the time that they reach enteral nutrition, but there was no benefits with bronchopulmonary dysplasia or retinopathy of prematurity or intravascular hemorrhage. The dose and the treatment time, more research is needed. The latest is February 2023 about a society paper of the SPAGAN, probiotics for the management of pediatric GI disorders, and they mentioned the neck. And they had recommendations, reducing the risk of neck in infants, provided safety, that all safety issues are met. You know the strain, it's evidence-based, it is eligibility criteria is met, that LGG, Lactobacillus rhamnosus, at a dose, and they even gave the dose, at a dose of 10 to the power of 9 to 6 times 10 to the power of 9, or a combination of Bifidobacterium infantis BB12 and Streptococcus thermophilus at the specific colony count are recommended. So this is the first recommendation. Due to insufficient evidence, no recommendation was given for Lactobacillus reuteri or Bifidobacterium bifidum or Lactobacillus acidophilus in these patients. And due to lack of efficacy, tried and it was not effective, they do not recommend the Bifidobacterium brevi or the Saccharomyces boulardii. So these were really specific, and the grades were weak, yes, but they were at least combining all the research done in necrotizing enterocolitis. Are they safe? Probiotics are generally considered safe in premature, and lack of serious adverse events from multiple clinical trials in premature term infants is reassuring. What about allergy in early life? Gut dysbiosis, as we know, correlates with allergy development, and LGG, Lactobacillus rhamnosus, was the most studies in this and how it stimulates tolerance acquisition in infants with cow milk protein allergy. This is another scientific report, an RCT, about the influence of dietary intervention in epigenetic mechanisms and how it accelerates the healing of cow milk protein allergy and acquisition of tolerance. Another study about the prevention of GI infection in children and how Bifidobacterium lactis BB12 was effective when supplemented in the formula, in the infant formula, in prevention of GI infection. BB12 also has been studied in GI health associated with prevention of GI disease, colic sometimes, upper respiratory tract infection, immune function, and skin health. Different strains in different disease. We know that probiotics are disease specific and strain specific. So this is the latest review about the effectiveness of some strains in some diseases. Acute gastroenteritis, we have the rhamnosus, the reuteri, the boulardii, acute gastrointestinal infection, the reuteri, antibiotic associated diarrhea, the rhamnosus, the nosocomial diarrhea prevention, rhamnosus, infantile colic, reuteri, regurg and IBD, rhamnosus, reuteri, constipation, no significant effect of probiotics till now, ulcerative colitis, the reuteri, the Crohn's disease, no significant effect of probiotics, and atopic dermatitis prevention and treatment, L-rhamnosus, was really evidence-based in this domain. So my key messages are, a balanced gut microbiota is crucial. We work on our microbiota. They are more cells than our own cells, so we need to work on them. An altered gut microbiota composition or activity, dysbiosis, decreased diversity, increase in the pathogenic bacteria contributes to disease. Targeting gut microbiota in neonates using biotics has the potential to treat or even prevent disease. Not all probiotics or even prebiotics the same. We need to know that they are strain specific with a specific colony count, adhering health effects specific for specific disease. The clinical effects and safety for any of them used alone or in combination should be evaluated separately. I'd like to close with the George Bernard Shaw saying that science never solves a problem without creating 10 more. We still don't know a lot of things. For how long should I give the premature probiotics? For how long should I give post disease or during the acute infection or post? The timing is still vague. The colony count is still vague. The use of some strains, the combination of strains, we need a lot of research working on these subjects. And thank you.